Presentation. This time we're going to move quickly into our panel, and so I'll ask our panelists to come up. Our first presenter is Dr. Kishore Malavade, and I'll ask him to come up, and I'll ask the panelists to be seated, and we'll go one by one. So Kishore Malavade, Dr. Malavade is first, and next Heidi Arthur, who is a principal at Health Management Associates, and then Mark Redding, who's a co-developer of the Pathways Community Hub model. And we'll go in. Also, sorry.
Kim. Just say Kim.
Kim, you'll also be joining this panel. Do I need to replace one of the mics?
No.
Okay. So Kishore, I'll ask you to start off and give your presentation, and then we'll go one after the other, and we hope that we can have some time just to have a little bit of discussion.
Sure. Hi, everybody. Can you hear me? Yes. Okay. So I am the Associate Medical Director of Maimonides-led performing provider system called Community Care Brooklyn. We've been working, and I want to thank BPN and everyone who's here bringing this together. I was here last year. We were really, I think, in the early stages of talking about this hub pathway. Just a little background on where we've been and how we kind of got here. Unfortunately, David Cohen had to leave, who's the executive director of our network. We really started working on things like this about 10 years ago, focused around what was coming down the pipeline through the federal system, which was health home funding. And what we knew is that we were attempting to think about how we could coordinate care better, and we were really interested in actually doing this around the population in Brooklyn with serious mental illness. And so we got an innovation award to think about how to better coordinate care for that population. The themes that I'll just quickly highlight here are that was investment money in a population that was underserved, that had tremendous social issues, real disadvantages in employment, education, and what we knew is we needed to help invest in the workforce, non-clinicians, health home care managers. We felt that the folks on the ground in the communities were going to be the most important people in addressing that population. But I want to say the most important thing that came out of that was a collaborative effort and a collaborative governance structure that worked with community partners, social service agencies, community agencies, housing, economic development. We all worked together on that project. Friends like Kevin Muir in the back, who's going to be speaking, was part of that governance process. That really leverage was for us how we moved into this district landscape, which I won't go into too much, other than the two important things that weren't part of really explicitly enough part of district, but I will say, we felt it was important. One was community engagement, and we've been working with a number of partners in this room and around the borough on doing participatory action research. First in Brownsville and East New York, then moving into Bed-Stuy and Crown Heights, and then into Flatbush, and then Flatlands and Canarsie. We recognize that if you're going to invest in the public healthcare system, you really have to start investing in the community and start listening to the community, hearing what the problems are from their perspective. How can we then start working on solutions together? And really, that work has developed well beyond healthcare. It's about so many inequities in our system, and it's focused on housing, it's focused on economic development. Again, as everyone here knows, and people have spoken to, when you start looking at things in silo, you have to look at it together. And so I will say that's been our most fruitful efforts. The big miss in district is that it wasn't entirely invested in mothers and infants. I mean, if you're going to think about population health and how do you improve the population's health over the next 10, 20, 30 years, you need to start investing there. So we are working with the city on Maternal Depression Collaborative at the mayor's initiative, his request. We're working on funding not only healthcare and care for depression, anxiety, and stress in OBGYNs with trying to develop a larger midwife workforce. But we think those kind of investments are the most important things we can do. And you really have to start addressing things from the beginning, and you have to start addressing a much broader range of issues for every individual in every community to make a difference. So I will end there. Thank you.
Thank you. Those were excellent remarks. Can you hear me, Maya?
No, pull it up.
Now can you hear me? Excellent, thank you so much. My name is Heidi Arthur, and I'm a principal at Health Management Associates. I'm a woman, I'm a mother, and I'm a healthcare consultant, so I can't actually speak without a slide deck, so thank you for putting that up for me. I'll make sure I can advance this. And I've been working with BPN and the community leadership team for the past, since we started the feasibility study. It's been about 18 months now. We've really been working hard together to come to this point, to be prepared to talk about the Pathways Hub approach, which really is the right approach for this time. And I've also been a consultant with Communities Together for Health Equity, and have been I'm a social worker, but I'm a healthcare expert. And now, after 18 months with Communities Together for Health Equity, I have been schooled, I have been taught about the vital value of community-based organizations and how critical it is. I feel like I need to be an advocate and an anti-racist champion within healthcare system reform efforts, because what often happens, what too often happens, what did happen, even in this progressive state, is that the vital voices of community-based leadership and community-based organization get left out of the planning discussion, left out of the service delivery design process, and we're not going to get the kind of root causes of the causes of poor health addressed without grassroots interventions and community-based leadership in deciding what those problems are and what those solutions need to be. And so the Pathways Hub model, I think, is so exciting because, as Kishore pointed out, there's a lot going on the left side of the equation in terms of investments. $8 billion in DSRIP funding as just an example, and the Health Home Initiative is another example of funding that went into the clinical delivery system's effort to engage in the community space. But there's not been a similar type of investment in such a coordinated and focused way on the left-hand side, the right-hand side of the slide, around how to align community-based organizations that are already such important and valuable players in places like maternal child health in cities like New York. There hasn't been a similar focused effort to engage them in the reform effort. And so what we have right now is the opportunity. Right here you see like a lot of the community leadership team members, BPN, the Caribbean Women's Health Association, all of these organizations are out there. They're seeking funds. They're trying to sustain their vital services. They're getting some tremendous support, but not enough support to keep doing the really critical, important work that they're doing. And they're all working separately. Often, they're coordinated through some of the new initiatives, but frequently they're trying to get funds and they're operating without coordination and without alignment with all those investments that have happened in the delivery system side. So they're still trying to get grant funding, they're still trying to advocate for city council dollars, they're still trying to do all of these things. But if you look at the Pathways Hub approach, which is what we're advocating for today in this event, it actually starts to align and pull them in the same direction and give them sustainable financing methodology that will help them begin to access and engage with and effectively receive funding for the work that they do within the context of the delivery system. And so as you can see up on this slide, what Pathways Hub offers is a very standardized approach to measuring impact. It offers a coordination strategy that helps align all the different work that they're doing, and it helps to provide a really clear and focused cross-system capacity to identify shared understanding of risks and a payment methodology to support those organizations in actually making an impact and changing and mitigating those risks. So this slide really goes through the core features of the Pathways Hub approach, and I'm up here with Mark. We collaborated on developing some slides that just sort of identify some of the main takeaways. These component parts are so critical because what it describes is the hub as a convening entity and the pathways as those risk mitigation measures. And the hub model that BPN has been identified to lead would actually help to coordinate resources from the healthcare delivery system, but also sustainable funding through managed care reimbursement, as well as aligning resources and blending and braiding funding from other funders and payers in a way that helps to really establish the infrastructure that we know those CBOs really, really need. and it provides an incentivized model for community health workers out there doing the kind of engagement work, the sort of the work that a sister friend like from BPN can do that a health home care manager with a really large caseload is not going to be able to achieve. And so this model just identifies that for the maternal child health population, as Kishore noted, that hasn't been the focus of one of these large system-wide efforts. There was an option for DSRIP funding, but not a whole lot of folks selected it. The delivery system has done a lot to start coordinating its infrastructure. This model would do the same, but to pull in and align the efforts of the community-based system. And the hub would then allow for those organizations to partner more effectively with the formal systems in really identifying where there are gaps in the available services to address the social determinants of health, so that collective efforts to finance those gaps, to fill those gaps, to help right the balance between how we support social services and how we support clinical services can really be addressed at the community level, informed by the folks who know it best. And so the infrastructure is all about coordinating, training and certifying community health workers and sharing metrics around quality management that everyone can agree with and understand, identify gaps in social determinants that everybody needs to support better funding for, and really help to support collective planning. So these are just a couple of slides that really highlight how the model, the methodology is focused on risk reduction by identifying agreed pathways. And we know that it improves outcomes because there's research with return on investment data that demonstrates its impact. So I won't go into that, you can get the slides afterwards, but we know it saves money and it improves outcomes, and it's kind of a no-brainer, truly a no-brainer. Because if you're going to break the box, you gotta figure out a strategy to build something that will work, and we think that the Pathways Hub model is exactly that strategy. So I'm going to turn it over to Mark and let you describe what the model actually looks like in real life.
Thank you, Heidi. Well, thank you all for this event. It's awesome, and I've been working with Heidi and Gozi and the team, and I think we've all been infected by the same brain virus that has just taken over our enthusiasm and excitement, and we're very happy that it did. As I've been working with Brooklyn Perinatal Network and getting some credit for this hub model, I think there's been folks that have been suspicious that a guy like that would come up with a model like this. And so I finally brought the expert, Kim Finnessy, who actually really taught myself and my wife and others who built the model the basic components. And as part of introducing Kim's part of the presentation, to really simplify what we're trying to do here, it's about reducing risks. It's really that simple. And we didn't know anything about risks when we started. When we first hired and worked with Kim and her colleagues in a very at-risk community, we told them, you've got to get them prenatal care, and that's all we do, and that's all you're supposed to do. And I remember scolding them for working on getting people housing and food. And it wasn't really till I had this little family with an 18-month-old living outside, expectant mother, and it was sub-zero temperatures, and I had been scolding that community health worker for not getting her prenatal care, that I realized that for that person, that housing and the prenatal care were intrinsically linked together. We have a system that wants us to break people up into parts and treat the parts. Kim and her and the community said that we got to see and treat the whole person. And the science, if anybody's willing to get together and go over it, is really coming in support of what Kim says, and we're trying to follow that as much as we can. So with that said, if simplicity can be a huge tool for us, so if you would come along with me for a moment that it's about addressing these risks, what that really helps with is these things that Kim had been working on, and now her team works on a lot: housing, daycare, food, clothing, adult education, employment, specialty care, medications, getting their medications. These are all outcomes. So Michael Porter, the most published value-based payment author out there, says that the most important outcomes are the outcomes that are critical to the patient themselves. And we may not think that getting daycare is a major outcome, but try having 4 kids and being asked by social services to support yourself and not having daycare. It's a major outcome. And so what's fascinating if we look at it in this way is these, what some of us might consider smaller outcomes like food, clothing, housing, daycare, you just go right down the list, lack of knowledge about safe sleep, lack of knowledge about safety. These are all outcomes, and they're way more than process measures. If we can track them and if we can identify and address them, and she handles up to 120 different categories of risk factors that get mitigated in a pay-for-performance model. If we can do that, it not only has been shown to significantly improve birth outcomes, but it also improves education, chronic disease control, employment. In other words, or recidivism, HIV, if you think of those categories of individuals, every one of the people suffering in those conditions have multiple risk factors that need to be addressed. And so if we are helping a family of an expectant mother with all those things, we're also improving that kid's chances of doing well in education and other items. We can go into a little bit more detail about, in the questions, about how the mitigation of these risks is tied to pathways, and those are then in payment models that have been led in the development by Medicaid Managed Care, who also has a lot to do with what's going on here in New York. But I'd like Kim and I would like to kind of show you how a client works through this model, and we think that will highlight it best. So first, this client might have been referred by their managed care plan, by their social service provider, or in many cases, Kim.
Most of the time it's someone I already know. First, I would check with the hub to make sure that they're not being seen by another community health worker or someone doing pathways. Next, I would connect with them and begin the enrollment process. I would find out first what's their most important problem they're having. I would complete a demographic and risk factor checklist. The checklist identifies their health, social, behavioral risk. Then I would pick the pathway that would be beneficial to them and address their needs. Me and a team, including a nurse supervisor, would review and confirm the vital pathways. I would work through the pathways and connect them to housing, food, education, medical care, and many others. While working on pathways, I'm building a relationship with them. I'm visiting them as often as weekly or at least once per month. Depending on their needs, I may continue to see them for a few months or up to 2 years. Some success stories have been, some of my clients have become nurses, social workers, business managers, and most importantly, they have healthy babies, and the client is moving back on their feet and supporting themselves and their families.
So, hopefully I can speak loud enough. Just to try to make a little bit of sense. Kim's working from out here in the community, and she's tied to a community-based organization like Diaspora. You have a number of them right here in the room, and they are her employer, and they are connected to the community. They're in the community, and she's finding the person. She's completing this checklist. She's figuring out what risk factors they have. She's assigning the risk factors to a pathway. The pathways through the national certification all have a code number associated with them, and the 5 managed care plans in Ohio have payment tied to those pathways, and then she doesn't get credit and nobody gets credit until if I'm her client and I don't have housing, then she's got to confirm I got a safe place to live, or if I don't have medical care, I showed up and the nurse and the social worker signed off on it. And same for the host of other risk factors. There's multiple community-based organizations with multiple community health workers out in that community. So just left Toledo, when they get all their community health workers together, which they do on a monthly basis, there's more people than in this room. It's a whole network of agencies. Instead of working in these broken silos, they're working together. And if the agencies don't get along, don't worry about it. The community health workers get along just fine, and they refer and they work with each other and they make it happen. What the hub does is it's not just a big state federal agency that's a million miles away. It, by national standards, has to be close, has to have community members on the board. it's tracking all these risk factor reductions across all these other agencies. And it's got the horsepower to have contracts with Medicaid managed care, with major grant initiatives, with the state. So they usually have about 15 funders. And the newer ones, obviously not as many. What that does is, if a client shows up that's undocumented or doesn't have paperwork, anybody who shows up that's significantly at risk, there's a funder through the hub that's agreed to pay for that client, and she doesn't have to turn anybody away. And the CBO, which I think half of the care they provide right now, as we see it nationally, is free. and so the other thing that's happening is the average, and this may be a little out of date, but the average employment for a community health worker is less than 2 years, because they're usually grant funded. Kim's been funded for 20 years. She gets a substantial, because she's an excellent CHW, she gets a substantial increase in her pay, which starts at a fair rate and benefits, or I hope it's not fair enough, she should be making $1 million, but she gets a significantly more based on her performance. And the community health workers across Ohio have, we think, have maintained employment and been better paid, in some cases better than nursing or other careers than elsewhere in the country. I'll look forward to talking more about it. So excited to be here. Please ask Kim any questions you got. I'm so glad she was able to be here too. Thank you.
So thank you so much for that presentation. I know we'll hear a little bit more specifically as we bring up the next panel, what's going on. But before you leave, I know that some people need to leave. There is an evaluation form in your, it's a yellow sheet that's in your packet. I'll ask you that you please fill that out. We really need your input and your feedback. It helps us a lot. So if you can fill that out and leave it in the basket at the back table, that would be greatly appreciated. So thank you. I'm going to dismiss the panel right now and call up the next panel. And for those folks that are on there, the patient group, I'll ask Denise to just call up who those are, and we'll ask them to come up. And if we have any questions towards the end, we'll hold our questions for that in interest of time.
Thank you. Let's give another round of applause. And we do have index cards if you need to write down some questions, because Mark and Kim will be coming back up after that, so there may be some questions that we can come around. Now, we've heard a whole bunch. We've heard what we needed to do. We've heard from the elected officials of what they are willing to do and what we're going to be accountable for. Mark, Heidi, and this panel just showed what the Pathways Hub can do and gave you a sort of synopsis of a client. Now we're going to hear a client story, and we're going to highlight what our coalition does. So I'm calling Heather. Yes. Woo! That's right. From Heather Daly from Diaspora Family Services. I'm calling Sharon Rose, Executive Director from Christopher Rose Empowerment Campaign. Mark and Heidi, I'm sorry, we're just going to allow you to have exercise. Y'all are coming back up because you're going to, I'm saying Mark and Heidi. Mark and Kim are coming back up. So what are you going to stay here, Heather, or are you going to come here? You want to read it from here? Okay. This is going to show how the coalition works together, a client story, and how it touches our organizations, the work that we can do, and you're going to hear what some of the barriers that's already in the system. And then afterwards, Mark and Kim are going to be able to highlight. Now, if we had the Pathways Hub, this is how it can enhance. Y'all looking at me.
Excuse me 1 second.
Yes. Daphne? She's coming? Okay. And after they do their piece, we're also going to have a client that's going to share her experience, and that's the most exciting part, is to always make sure that we get a client. As she's coming up, Heather can go ahead and begin.
Hi. So, just to give you some context of who I am,
I'm the program manager for Maternal Group Home or Transitional Living Program at Diaspora for young mothers. So we serve young moms who are age 16 to 21, and they can stay in our program up to 18 months. And we assist them with a whole range of services to help them transition into more independent living with their families. So that's what I do. Diaspora does a lot of things, but that specifically is my program. And what I was tasked to do for this panel was to put together like a case study or a case vignette, a story that may look typical of a woman or a young woman coming into my program, and then how they may be served by all the different resources that exist as of today, and in Brooklyn through the Brooklyn Perinatal Health Coalition and other partners of the community. So I'm just going to read through the vignette that we put together. Okay, so. And this is a narrative, it's not an actual client, but everything that's in it is absolutely could happen to a client I'm in. Every single one of these things I've seen happen, so just to give you some context. So I'd like to share a story with you of a young girl named Ruth Jean-Pierre. Ruth came to the United States from Haiti after the 2010 earthquake when she was 11 years old. She was sent to live with an aunt in Brooklyn, and her aunt had several children. And Ruth slept on the couch in her room. Ruth attended school but was not allowed to leave her home when she was not in school as she was made to watch her children. Her uncle abused alcohol and would take out his anger on her. Ruth's school counselor discovered the abuse one day when Ruth went to the school nurse complaining of a headache due to a blow to her head from her uncle the night before. Child services were called and Ruth was placed at age 16 in a foster home. The foster home was a safe place for Ruth. And she was able to obtain her green card. She continued to go to school but had difficulty keeping up her grades because she could not concentrate. She began to fail several classes and was behind in school. Another foster child moved into the home and Ruth and she did not get along. So at 18, Ruth signed herself out of care and began staying with friends on and off as well as sleeping on the train. She even traded sex on some nights for a place to stay. Eventually, an outreach team recognized her in a train station, and they helped her find a youth crisis shelter. Ruth found out that she was pregnant at the crisis shelter. She was referred to several mother and child programs, and Ruth was offered a bed at Diaspora's Mothers Getting Home Transition Program, which is a program for young homeless mothers 16 to 21, with the agreement that she would engage in mental health services. So I'm just going to pause. This just gives you the background of, and this could very well happen to any of the young women to my program. So I just want you to think about it. So Ruth's finally found a safe place to live, but now what happens, right? What happens now that she's in our home? And this is where Ruth's story might look as a result of accessing services through the Brooklyn Perinatal Health Information Technology System, which right now is the portal that exists to screen clients, and it's a closed loop referral tracking, so it helps us basically refer folks within the Brooklyn Perinatal network that exists. And then as well as some other community partnerships. So upon intake, Ruth's case manager at Mothers Getting Hope conducts a screening for perinatal risk factors, depression and chronic stress using the Brooklyn Perinatal Health Information Technology System, and refers Ruth to connect with a doula through Healthy Women, Healthy Futures at BPN, as well as a visiting nurse through the Nurse Family Partnership. I have to pause. I love that program. We have a nurse that comes and she sees almost all of our girls, and we just love her. They do amazing work through SEO. She's referred for mental health services in Interfaith Medical Center and to the Sister Friends program for additional emotional support. She begins receiving group prenatal care as part of centering practice at local community-based hospital clinic. Youth is referred to and attends newborn, birthing, and breastfeeding workshops through the Caribbean Women's Health Association and Healthy Families. She also receives one-on-one breastfeeding counseling, individualized family support visits, and attends stress reduction workshops in the community with Christopher Rose Community Empowerment Campaign. Her case manager assists her to return to school in a young adult girls center that has a life nursery available when she gives birth. Ruth's referred to Fort Greene SNAP for assistance with her resume. She searches for employment and is able to find a part-time job in order to save money before baby's born. She continues to attend school until 2 weeks before due date, gives birth to a beautiful baby girl named Sky. Doula is present during her labor, and her baby's born vaginally at a healthy birth weight.
At discharge, her daughter Sky is showing weakness in one of her arms, so calls placed to early intervention, and she receives physical therapy through early intervention. And they come to visit her in her home. Ruth is also connected to culturally competent pediatrician for Sky. She's a good mother, very attentive because of her responsible parenting workshops with fourth grade staff. And after she's cleared by her doctor at 6 weeks, she goes back to school and is able to finish school with the help of the Life Nursery, and she hopes to become a nurse. Clearly, this is an idealized story, right? We all wish that we had a client like Ruth who's very engaged and follows up and does all her appointments and does everything you ask her to do, which doesn't always happen. But we wanted to use that as just an example of how someone could access all the variety of services available in Brooklyn. But there are barriers. There's a lot of barriers for women like Ruth. I know I'm too wrapped up. And I wanted to just highlight some of those. So a lot of women, Ruth is fortunate, she has a case manager in her housing program that helps to follow up. Most women come in and they have to do all that follow-up independently. So managing health and social needs for multiple service providers can be very overwhelming, and clients are more likely to disengage from services. There's a risk of re-traumatization of clients that have to share their psychosocial history over and over and over and over again with every single place they go. There's inconsistent messaging across multiple providers. Clients are being treated, as Mark was saying, for the parts and not the whole. There's too many case managers, navigators, care coordinators. You have a different worker at every single place you go. So there needs to be like a centralized case manager or a community health worker. There's inconsistent information sharing and screening of clients. So when you have a hub, it centralizes things. You're all collecting the same data. It's all stored in one place. You don't have this people doing their data, this people doing their data, and then having to like piece it together like Frankenstein to figure out what's going on. There is non-standardized training and practices, so there is inconsistency of quality of care among different providers. So those are just some of the barriers that our women face when they go through these systems in Brooklyn, and they're going to talk a little bit more about how our hub can kind of solve some of those issues for us.
Thank you, Heather. As Heather clearly described some of the pathways or some of the issues that sometimes clients can face coming into the system with duplication of services, multiple providers. And the Pathways Hub system is one of the methods or the systems that we're trying to implement to be able to address and resolve that. It's starting with the coalition, which is the CLT, better known as the CLT. The coalition currently is made up of organizations you see here, the 5 organizations: Brooklyn Perinatal, which provides the overall coordination and the engine behind developing this Pathways Hub; Diaspora, which Heather so eloquently talked about the services they provide for their maternal group home pregnant teens; Christopher Rose Community Empowerment Campaign, which we do social support services within the community for families and children and women, pregnant women, to a range of in-home and one-to-one services. And we have Caribbean Women's Health Association that provides a lot of the ongoing workshops, parenting, breastfeeding, and safe sleep activities. Did I leave anyone out? And for Green Snap, we can't forget workforce, because we all need to survive. Economic health is also very important to the families that we serve. And Fort Green Snap provides some of the other wraparound services like career development, resume writing, and helping people to find and support living wage jobs. So based on Heather's testimony, I don't know if Mark has any comments to say how the Pathways Hub might then be integrated into what she said. Like in that situation, which pathway would that particular young lady take?
So we have this part of it open to some more open discussion, but Kim and I have prepared a couple comments. This demonstrates, and obviously it's been very visible with the visits and with the interactions we've had so far, that Brooklyn, thanks to the team here, is in a very high state of readiness for a number of different evidence-based, focused, pay-for-value models. You've got great programming, you've got a great network put together. So it's an ideal place for a model like the Hub model, and you simply just need to decide what will be the most helpful. I think the other thing to just mention, the hub model at its best should not hold back innovation or what communities have already learned. There's areas where you guys are way ahead of anybody that we've seen nationally. And so the hub model should be more like a set of Legos that you can put together in a way that makes sense to you. And the national certification can help make sure you do that in a way that fits with some of the basic evidence, as well as fits in a way that will work for payment and scientific evaluation for whatever that's worth. So, so a couple of highlights. Again, no matter who this client was, there should be a funding resource depending on the development of your hub for them. So it should not have to be, this client was undocumented. So in the Ohio hub, United Ways in Ohio have committed to serve clients who are undocumented and to pay the CBO for serving those clients until they can get documented, get on an insurance plan, and then the insurance plan takes over.
Oh,
Yes.
the client is supposed to.
What's that?
Okay,
We want to get your documents,
Okay.
yes, to share.
Thank you, Mark. As we run out of time, I'm going to get back to you,
No,
Kim,
take
in
your
a while. But we also want to present another scenario to you. This was a scenario of a young woman who's a teenager that might come through that teen support pathway hub. And also I wanted to mention another scenario, which is the presentation of a young woman, healthy, fairly healthy, walked into the community, and how the Pathways Hub can then assist her in being able to deliver a healthy baby with minimal invasive intervention. And I don't know if I'm using the right words. But anyway, I want to present to you Daphne. I'm going to give you a little background history on Daphne. She's sitting right here, so she hears everything I'm saying, so she knows. I know I want you to encourage her, and she's here with her beautiful baby. But Daphne was first referred to our organization, Christopher Rose Community Empowerment Campaign, by one of our CLT partners through the Caribbean Women's Health Association, where she received childbirth training and pregnancy, child care readiness. Right. Say, see, what are you going to do that?
Sorry. Caribbean, I attended to some workshop in Caribbean Caribbean Women Health, and they teach me how to breastfeeding, all that kind of stuff. And when I was before to go to Caribbean Health, it's Miss Anna in Kings County. She introduced me to Caribbean. Yes, she's Miss Anna is a good woman, and she's very great. And when I started to participate to the workshop in Caribbean Women Health, and I meet.
I'll tell the rest of it. Okay, I'm going to just finish the rest of the story, and then you can hear completely from her about her story after this. And so at Caribbean Women's Health, they referred her to the Christopher Rose for actually additional social support and some baby supplies and so forth. Thanks, Daphne. And during that time, we immediately assigned her, referred her to the birthing project, and assigned her to a sister friend who is Miss Wright, who's also the program manager at CREC. Miss Wright was assigned as her sister friend because Daphne speaks Creole, and Miss Wright is the only Haitian-speaking, Creole-speaking sister friend that we have, so she wore two hats, which a lot of us do. As a matter of fact, I'm Jamaican, so I wear 3 hats, I have 3 jobs. But anyway, but we all wear multiple roles and in servicing our community. So Elsie was her sister friend, and she also was referred immediately to Healthy Woman, Healthy Future, to BPN for a doula, to Perinatal Network. During that time, Daphne was extremely compliant. Daphne is awesome, very, very awesome. She does everything she has to do. She keeps every single. She goes to the neighborhood health action center for classes, for workshops, for parenting classes, for breastfeeding classes. She shows up at everything, and she's actually healthy, and she is expecting her first child. Yes, she's 38 years old, and she was expecting her first child. If any of you are familiar with our healthcare system, you know what that means in most of our hospitals. FLAG, AMA, it's flagged as AMA. So on November 28th, Daphne came into our office after one of our exercise class programs. She walked in at 1:30 and she says, I'm here to exercise because I need to have my baby. And so we were struck. We're like, the class is over, why are you here? And she said, I need to exercise, I need to have my baby because they're going to cut me, give me C-section. So we decided, okay, we got to sit her down, find out what's going on. After we discovered that there was no health problem, Daphne is completely healthy, no hypertension, no diabetes, no medical risk. They said because I'm 38, I have to have a C-section. So immediately we decided to track down her doula to find out what's going on and how can we then work with Daphne together to decide how to avoid this happening. Since she's completely healthy and she's only on her due date, she's due November 28th, this was November 28th. She advised us that her C-section was already scheduled for the following Monday. So she says, I need to have my baby now before the C-section come in. So we advised her that her doula and the team will then try to speak with the hospital and intervene so that she would avoid having a C-section. Anyway, after that, the ensuing days after that, she had an appointment the following day. When she went to her appointment the following day, they actually moved her C-section down. The following day was a Thursday, they moved her C-section up to a Friday. So she panicked, and she told us, we have to get something done. No. And Gosie's reminding me that hospital says to be named, remain nameless. Of course, I know that in Gosie. Hospital nameless. But regardless of the fact that we're not calling names, I just wanted to highlight the extreme, I don't know what you call it, connectedness of the resources that were available. Daphne got a second doula because her Healthy Woman, Healthy Futures doula had got assigned a new job, so she wasn't able to completely assist her at that time. So Denise West, I spoke to Denise West assigned a second doula. Who has two doulas? But this is what we do for people. For people be like, we actually see people. I saw the fear in her eyes. We saw how nervous she was. We saw the need, and we spoke up. I called Ngozi the next day when she was at the hospital. I said, Ngozi, we got to do something. This woman is going to have a C-section. When we call, they say because of AMA, she has to have a C-section. Ngozi called up, got some names. Denise called up, got some names, and before you know it, intervention was done. And the next day, which was a Sunday, December 2nd, Daphne delivered a healthy baby girl by natural delivery without a C-section. Now, some of the ways that the pathways can help. Daphne remains completely compliant. She's breastfeeding. She got breastfeeding instruction in the hospital as well as by her one of us.
Yeah, and I'm currently in women health. Yeah, and I say thank God because God was with me when I was giving birth because it was very difficult. I was in the hospital on a Friday morning and I delivered my baby on a Saturday morning at 6 a.m. And it was very difficult night. But I say thank you to my doula, Stephanie, she was very great, and my husband too. And thank you to the doctors, but first God is with me. Yeah. Great goodness.
So some additional services that Daphne could benefit from. I said she's attending all meetings. As a matter of fact, last week she attended the massage program at the Neighborhood Health Action Center. I believe they have massages.
Yeah, Bristol.
Bristol. Yes, so that's some of the services she attends, and she keeps all the babies' appointments. Her husband is happy. He's supportive. He's part-time employed, so he's looking for additional means of supportive employment that we could then actively support this family and increase their economic chances of success. So that's one of the ways that we need to build into the pathway economic resources, jobs, employment, training, certification, so that the families, in order to remain healthy and to sustain health, they say health is wealth, to sustain that we have to build all sorts of other systems. So we invite other partners. If we provide a service that can help anyone, that other families or families can access other resources, consider joining the coalition and adding to the services that we provide, and consider yourself as one of the pathways. Sorry.
And if they can try to it's so difficult to people to find a place to live. I see they build a lot. They build a lot buildings, but it's so difficult to find a place to stay. It's very hard for me to have a place to stay before I get my baby, and they take a lot of money on my hands to find a place. It's not fair. It's really not fair. The government supposed, the mayor or the government supposed to say something on this thing, because they have a lot of people can afford to get a place to stay, because it's very high to get a place to stay. It's not fair, really. They're supposed to say something and to give people to have an opportunity to get a job, to go to. Thank you.
Thank you, Daphne.
Thank you so much, Daphne. I thank you for your courage. I thank you for your persistence. I wish that you had come early in the program, because I think a lot of people needed to hear that. And a lot of times, things do not come alive until we get a personal story. Sometimes we talk about things and they're spoken about in such abstraction. But thank you for the courage, and thank you for sharing with us today. And I thank all the partners of CLT for all the work that they're doing, because this really brings it home and brings it to our minds why we need to do the work that we do and why we go out and continue the work that we do. So thank you so much for sharing. Thank you for sharing it to this audience. It was really well received, and I really cannot underscore that I really appreciate your sharing this with us. I don't know, Kim, if you have anything to tie this into before we move on to the next group.
Well, I was just going to say that so many times, we harp on the prenatal, but after the baby's born, there are so many more things that can go on. There's more risk, there's more. So that's why it's important for the community health worker to be in the home, because we see this, we hear this, we know, like she said, having a problem finding housing. It's just more pathways that can come after the baby's born. So our goal is just not for them to have a baby and then we leave them. We yet stay with that family and to assess them and assign new pathways as they come along. So our goal is to have, like Heather said, have a client that is able to go on to school or get a job. That's our goal, is to work with them and provide them with the education to help them reach the goals that they have set for themselves as well.
Thank you so much. At this time, we'll excuse you all. We thank you for that presentation.